Well, good afternoon, everyone. It's 2 o'clock. We are going to get the 2 o'clock session started. Welcome. It's Sunday afternoon. For those who don't know me, I am Jen Hargrave. I am your current president of the AOCA, and I'm very happy to welcome everyone here on this Sunday afternoon. So we've heard about insider trading, and I'm going to rephrase, actually, how I'm classifying this upcoming lecture to insider education. How many people here are involved in negotiating with hospitals, whether it be for your own employment, for your RFP, for whatever you might have potentially going on? Exactly. It's something that's quite common to us. So today we have the great privilege of having a chief operating officer of a hospital who was formerly an anesthesiologist, who can give us some of that insider education and help us understand what the value propositions that hospitals are looking for, and give a great perspective how we as a specialty have the potential to really bring value to a hospital. So I'm very excited to hear this. I believe that Dr. Peterson said she has about a half an hour presentation, and we're going to open it up for your questions and allow you to use this time to make the most as to what you would like to hear. Now, let me just give you a brief introduction. I know many of you heard David's introduction of Mary Dale a few moments ago, but I'm going to start out a little bit differently. She is a passionate pediatric anesthesiologist. For those of you who have followed her over the years and had a chance to hear her lecture at other meetings, that's been one of her great passions. But since that time, she's taken on several leadership roles. She's been very involved in the ASA, a past president, and she's currently the chief operating officer at her hospital, which is within the Driscoll healthcare system at the Children's Hospital there in that area. So, Mary Dale, we are so grateful that you're here today, and if you could come and talk to us and give us a little bit of that insider education regarding leadership value that anesthesiologists bring. So, thank you.
Thank you, Jennifer. Really appreciate that. And I did see a couple of hands go up of people that have had to go through the painful process of RFPs. And I know some people are in the position of being scared about having to deal with an RFP. So let's just talk about that. So some of the objectives, really understanding why hospital executives may go out for a request for proposal, if you don't know what RFP stands for. Understand what it's expected of an anesthesia leader, talk a little bit about, what is leadership. We'll talk about all the challenges that you experience, especially nowadays with staffing shortages and trying to be efficient in our operating rooms, and then how do we demonstrate value. So from my perspective, it's sort of like the buck stops here, the problems come here, and the problems that I would rather not have to deal with that I think should be dealt with at a departmental level or a lower level, the number one is behavioral issues, all right? And so if you allow one person in your group to be toxic or not do their job well or whatever, it'll look badly on all your group. And, if you do a survey, that's probably one of the leading causes. It's either that or finances that would lead a hospital administrator to say, I'm done with this. They won't take care of the problem, and we're going to look to another group. I will also tell you that in a lot of contracts nowadays, if you are doing a coverage agreement, the contract will say that the hospital has the right to tell you, I don't want that person providing care over here, which also creates problems for you. But I've had to threaten that before. We have our ED with an outside contracted group, and during COVID I had one emergency room doctor that was doing some crazy stuff, prescribing ivermectin to kids, all that. And I said, nope, I'm not going to have that. He either gets on the same page with what we've decided are appropriate treatment protocols for children, or he's out of here. And so, we eventually, got him into the fold. But just kind of a warning that that's what's going on. And then, obviously, I want my, whatever I've agreed to with the group, I want them to cover that. Now, I realize that COVID, we had some, unexpected things happened. We had staffing shortages because people were out with COVID. You know, at first it was a long time, right? 2 weeks or whatever. So that was a challenge. So obviously there's exceptions to that. But in general, I expect, you know, us to negotiate what the correct resources are for you to be able to cover this number of anesthesia sites during these periods of time. And then really, if you want to add value, it's about understanding what that hospital system's strategic plan is. You really need to get with the CEO, the COO, and understand, what does the future hold? Are you going to open up another ASC? Is there demand that you're going to, you know, build new ORs? You know, what are your quality goals? You know, what kind of margin are you projecting for the next year? And so that kind of gets into that efficiency equation. I think really understand what the institutional objectives and strategic plan is and their metrics for the next year, and what the board is holding them accountable for, and that's where usually their bonuses come from, is the board, by meeting these metrics. So how do we get all on the same page? I think sharing data is important. So we need to understand and measure where we are so that we can get to where we want to be. So looking at both the operating room and out of operating room utilization, including the trends, is one going up or down? What kinds of changes in procedure types are more of your less open hearts and more, you know, really high-end procedures in your cath lab? Are there any changes in the length of procedures? You used to do a hysterectomy this way, and now you're doing it robotic. So did that change the length of time? Probably, at least at the beginning. And changes in patient acuity, that's very important for a facility. It obviously takes, I think, more of our time making sure that patients are ready for surgery, but it's also important that we're on the same page with our documentation so that they get that case mix index, okay? So CFOs look at this, your case mix index, because a lot of how Medicaid at least pays, you know, you can look at that, and as you see a case mix index in a hospital go up, you know, your resources are going to be larger for that, but your payments are usually larger as well. And we'll talk a little bit about that. Efficiency metrics. Well, you know, I know the surgeons are always moaning about, oh, you know, the turnover time. Of course, you know, they're thinking turnover time is when I walk out the door and walk back in. They're not, okay, so they've got their resident or their PA that are closing the incision. I can't wake the patient up until the incision's closed, and at least they're starting to get the bandage on, right? Then you got to transport to the PACU, you got to check out, you got to check in your next patient, you got to make sure your room is ready, blah, 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 blah. You know, well, they're out, you know, having a cup of coffee, right? And so, you know, a lot of times they don't realize all of those steps. But I do think it's important to accurately document when is the dressing on the patient, how long does it take for the anesthesiologist to wake up the patient, then get to the recovery. You know, these are sort of extra steps so that we're all on the same page. So, you know, when I have a surgeon coming and complaining to me about X anesthesiologist who's too slow, you know, I'll just say, you know, this is a team sport. And I said, do you want me to fire somebody because they're too slow when we have a shortage? Is that what you want me to do? Well, no. And I said, you know what would be really helpful is if you more accurately predicted how long your cases start. I've got data on that. And you are only accurate 52% of the time. It's really hard for me to get the right resources to you when you don't give me an accurate OR time, surgical time. I've got all the data, okay? So it works both ways, guys. And, you know, we got to play together. So all hospitals have certain metrics that they're paid by. So you're probably familiar with some of the CMS quality metrics, HCAHPS scores. You know, I mean, you can argue how accurate or inaccurate they are. You know, these are the patient satisfaction scores. And but if you don't meet some of these measures, there's a financial hit. It's a 2% hit. And so I think it is important for at least somebody in your department to understand how your hospital is being graded by these outside entities, and then what role do you have to play in ensuring that these metrics are okay. Now, we don't have good separate anesthesiologist patient satisfaction measures, but there are certain questions that are asked that how we take care of our patients can be overall reflective of their overall experience of care. So whether they suffered from nausea and vomiting, that's a big one, excessive pain, communication, that's another huge one. And I know we've got a person who is, her full-time job is really dealing with patient experience. And in our physician practice group, every month when we hold our meeting, I've got the physician scores all laid out on a spreadsheet, my VP does, and everybody can see where they are, okay? It's all transparent. And what that's done is some of the folks that were kind of at the bottom, they're like, gosh, I think I'm pretty good, you know? I love my patients. Why don't they love me, you know? And so that patient experience officer is able to work with the surgeon or whoever and really shadow them in their communications with patients. And sometimes it's a very simple thing. It may be a matter of, you know, people do better when you're sitting eye to eye with them and not over them, right? And so maybe you need chairs in the pre-op holding area so you're not leaning over people talking to them, so that you are speaking out. Just little things like that can sometimes really improve those scores. We have all these quality metrics, and I think you have to determine what is important for your group and institution to look at. So, you know, just a sampling of all the acronyms. You know, you've got the MIPS, it's in the Medicare system, NSQIP, which are the surgical measures, Anesthesia Quality Institute. If you're an ASA member, you can get free, you know, into that. This is just a sample. I'm not advertising or anything, because I'm sure the other EMRs have got some of these dashboards too. But this is just a sampling, partial sampling of our Epic dashboard that we've got. And so it's kind of nice because I can look at the anesthesia minutes and how much it's changed. I can look at sort of, you know, room ready time, room turnover time. I can look at how we're doing on antiemetic rates. And what's good about it is it benchmarks our hospital with other children's hospitals, so I can see how we're doing and versus others. And one of the measures that isn't on here but is in the dashboard was on the twitch monitoring neuromuscular blocker, twitch and reversal. And we weren't doing a good job of documenting that. And so, you know, once we got the data and pointed out to the group, it's steadily improved. And so, you know, now we're above the average. And so really, you know, some of it is about what you measure. So on growth, you know, how do we, you know, squeeze out that efficiency? How can we increase our throughput or the number of sites? And so I always like to say yes. That was my mentor, Dr. Ahrens, always said you need to say yes. We're a service profession, and you need to be able to say yes. And so I will say, yes, we can do that, and it's going to require XYZ resources, okay? It's not, no, I can't, you know, it really is a yes mentality, but it's really getting to that nitty-gritty of what is it going to take to actually implement that saying of yes. And so I think that's really important to have those conversations, but be positive and say, well, yes, but I can't do it today. I am desperate for ICU beds. I am full every day. I got a call this weekend that our outlying hospital had a child that had to be intubated because of seizures, and our ICU has 22 beds. We had 22 people in there. We said, look, we just can't. They couldn't find any other facility hundreds of miles away. We said, okay. So basically we accepted the child into our emergency department and sent an ICU nurse down there to take care of them until we could figure out how to get a bed. So sometimes, you know, it's when you've got shortages of resources, it's negotiating, you know, how to help people and how to say yes as much as you can. Margin. So how many of you are getting a subsidy from your hospital or another entity in the hospital? Anybody getting subsidies for coverage arrangements? Ready to do that trauma 24/7, the OB coverage. So how many of you work in safety net hospitals? What is a safety net hospital? So that would be, a children's hospital can be a safety net hospital. A hospital that does the county indigent work is a safety net hospital. A hospital that has a high rate of Medicaid is called a safety net hospital. So I'm sure a lot more of you would raise your hands if I told you that. A lot of academic health centers are safety net hospitals. And so, all of those are going to have a higher government payer mix and or uncompensated care mix. And the higher that mix is, and the less cross-subsidization you have from commercial insurance, vis-a-vis my last lecture, the more you are going to need a subsidy in order to meet your staffing requirements, whether it's, nurses, AAs, or physicians. And so, it's really looking at, what are you getting? The CEO is looking, the CFO especially, what am I getting, for that value, and what is it costing? And so I think you need to understand how hospitals are paid and how you may be costing a lot of money, but maybe you can provide value in another way. And let me tell you something. The operating rooms and the ICUs are the economic engines of the hospital. That is where the margin is. Most hospitals that are taking Medicare or Medicaid payments are basically paid on a case rate. It's called a DRG, a diagnostic related group, or APR DRG. So when a patient comes in with pneumonia or a hip replacement, it's one payment. And you can use like $1 gajillion worth of drugs or not so much. They get the same payment. And the only time that the payment changes from that to a percentage of billed charges or whatever is if it's one of these outliers. And there's this kind of huge area average in the DRG where it takes a lot of, money before that becomes an outlier. So everywhere that you can make sure that the correct case mix is in there, the diagnoses to support that DRG, the more the payment is. Likewise, everything you can do that uses being really good stewards of the resources will increase that margin. And that's how you can work with hospital administrators and say, yeah, I may be costing you this, but this is how you can make more money in the long run. So, what kind of efficiency initiatives can the group assist in implementing? How can you reduce the length of stay? That's very important if you're paid in DRG payments. And a lot of those things are things that were talked about earlier today. It's ERAS protocols, it's which helps with patient satisfaction. We are the experts in, the perioperative care, and so really making sure that, we're investing in these preoperative clinics so we don't have unnecessary cancellations, so that we are seeing the patients early enough to do prehabilitation for especially the frail and elderly population, making sure we're doing the latest and greatest for regional and post-op pain techniques. And this is critically important for the bundled payments that are out there in Medicare that are kind of, were voluntary now. I think it's less voluntary, but, for like hip and other joint replacements. So what do I expect from an anesthesia group leader? What would be good practice for an anesthesia group leader? I really do think you have to visit on a scheduled basis with hospital leadership, and it depends on the kind of hospital you're in, which leader, or a combination of those leaders that I have up there, whether it's a CEO, COO, CMO, whatever, and that you develop your own report cards and benchmarks on quality and efficiency, and you let them know, this is where we're doing great, this is what I'm working on now, and these are some of the areas that you can offer as value added, and some of them may cost money. I mean, our pre-anesthesia clinic, we thought we could offer a value added service and provide some surgeon satisfaction and decrease the cancellations, but it did require resources. We ended up hiring two nurse practitioners who had been longstanding OR nurses and really worked very well with our anesthesiologist and understood, some of those areas around what a child needed, clearance for to get into the OR. And it all goes to sedation services. That's a huge area for us. I know Anis Amaya, who's a prominent member in this group, he's been key in helping us with our acute pain and really promoting blocks and an acute pain service with epidurals on the floor for children and all that. A huge satisfaction for the surgeons and for patients too. And then I think meeting regularly with your other key leaders, whether it's nurses, surgeons, departments, and it depends on, how you have things organized. A lot of people will have operational surgical services committee where you can argue about block time and all those other fun things, but you need to be at the table in all of those areas. The other thing is, I like to see demonstrate leadership is, help run ORs, help plan and implement new programs, promote efficiency, and please keep the surgeons out of our offices, as much as you can. But, they'll still come in, I know that. But as long as I have the information of what my group is doing, our anesthesia group, in trying to provide great care to kids, I can be a good listener and sounding board. But I expect everybody to, as I said, work as a team and look at their part of the equation and having an efficient operating room. We want to, as an anesthesia leader, you want to make your administrator's job easier where you can. Believe me, there are a lot of challenges in running hospitals right now with shrinking margins. I know you're having challenges with the anesthesia workforce, but we have a huge challenge overall with the labor workforce, and it goes across all of my nursing staff, radiology staff, EVS, you name it, and it's a challenge right now. So, never say no. So it may be yes, and I need these resources, but it's really having that positive can-do attitude that really goes a long way. Insist on having timely anesthesia providers. And what does that mean? You used to didn't have to say this, but when you say you're going to have a 7:30 OR start, that doesn't mean the anesthesiologist shows up to the hospital at 7:30, right? So it needs to be clear, the expectations need to be clear that, really you should have seen and done everything needs to be ready to go. You need to be ready to go in the operating room by that time. And we measure that. And of course, I'm not happy to say, but more of our not timely in the OR processes have to do with my surgeons once again. Have you gotten your consent? Have you marked the site? Have you done all those things that you have to do? And so it's a shared responsibility in getting patients into the operating room. Voice efficiency about obstacles, but be careful about being too vocal about capacity issues, the woe is me kind of thing. And I think if when you look at your efficiencies, if you think, if I had another anesthesia tech, I could help with room turnover, doing those analyses, because that's an easier person to hire probably than it would be to hire another anesthesiologist or CRNA or AA. So, really look at all the things and other ancillary personnel that can help make your job better. NOR management, that's a huge problem, and when you go to other areas of the hospital, their sense of time management, I don't even think they always have clocks on the walls like we have in the operating rooms. It's like their idea of on time and how long it takes and all that, they're just, kind of a different world. And so I think it takes a lot of conversations to try to get their efficiency up. And if you're ever involved, like we're in the process of looking architecturally of building on and creating new ORs and areas, and I'm always asked this question by our CEO, well, Mary Dale, should we have a separate ambulatory care area from our other surgical area? And I'm like, no. I said we should have an area where we can have on one floor where we can have patients, evaluated, go to the OR and go right back, which we don't have right now. That's what we need. And I don't need our procedural rooms in Timbuktu. That's what I need. I need all of it together. That's what makes not just the anesthesia resources, but the nursing resources the most efficient. And so the other thing, this is from some of the practice administrators, is, be careful about publishing schedules that show all your people that are on vacation. Just say, no, this is the number of people that we have available to work, and hopefully it's the same number, mostly the same number of sites every day or whatever you agreed to. But you don't need to overshare. Know your data, and so as we're looking at flexible scheduling and maybe people coming in a little bit later some mornings and staying later, or looking at some of those opportunities, really studying when surgeons want to operate and when you can provide that flexibility to your staff so you're matching the schedules a little bit better. And it helps, I think, in understanding where you can offer more block time or where people aren't appropriately using block time, and what are the penalties if you don't use half of your block time for 2 or 3, those are all those things that need to be in your governance structure that you negotiate, so that we maximize our efficiencies. I mean, there's nothing that irritates the anesthesiologist more than, being at the hospital at 6:30 in the morning, you're ready to go, and then there's some other delay, or, your room is done at noon, but then you got to stick around till 3 to start again because of all these inefficiencies. And so, really trying to match up all the labor is, and what the needs are is really something for those that love that kind of organizational work that is very helpful. Once again, just remember that the ORs are the profit centers. It's a very expensive center, but very high margin when you do it well. We know how challenging scheduling is, and you guys are the experts. So make sure you're partnering with the nursing staff. The schedule changes every day. Some cases finish earlier, some later. You have add-ons, whatever. Working all those in. You guys work your magic every day, and I think it's underappreciated by a lot of the surgeons how much you're doing running that OR board. It's a valuable resource for all of us. And schedulers and scheduling is the key. So, if you're in a private practice, it behooves your office administrators to be friends with the surgical schedulers and treat them kindly and really work with them and try to get things scheduled the right way. So, flip rooms, what are the policies and requirements? Obviously, a lot of surgeons love it because, they get out sooner. It's not always the best efficient use of resources from my perspective as a hospital administrator from anesthesia and OR nursing. But we're going to be opening up a new hospital in the Valley where I don't have sort of a closed group of physicians as people in private practice that'll come in whenever they can. And that's the culture down there, and that's what they expect. And so at least at the beginning, that's what I'm going to have to plan on. And, people make a big deal about timeliness of first cases, and I think it never should be that the case isn't on time because of us, but I think there was a recent paper published that showed it was really inaccurate surgical prediction of cases that wreaked more havoc in the schedules than even timeliness of first case. Once again, the scheduling, you should have rewards and punishments for block scheduling. If people are using up all their block, give them more time. If they're not using it, take some of it away. The schedulers, once again, you want to group cases together where you can work with the schedulers and let them know what works best for the anesthesia services that you're providing, especially nowadays. If you're in a disciplinary practice where you have some peds cases and some of these, getting those grouped together really will help you in your efficiency as well. Post-op pain, we had a lot of lectures this morning on the value of all these protocols, and it's really amazing how far it's come. I remember when I had my first ACL repair, the gold standard, the patellar tendon transfer, I was miserable. I was miserable for months, Don Joy brace for a year, eventually I recovered fine, but I never thought I would not have pain. And then the second time around, I chose a cadaveric implant. I think I took one narcotic pain pill the whole time, was back up and going within a month, very little PT required. It was just, we've come a long way with surgery and we've come a long way with anesthesia, and it is so much better now that we can be a little bit less invasive, and we need to really push people along like we talked about this morning. We need to take charge of that preoperative process so it's seamless and consistency. Oh my goodness. So how many of you will have the situation where anesthesiologist A sees the patient, good to go, the patient comes in, anesthesiologist B says, nope, they're not ready. Oh my God. I get that complaint from surgeons, especially during COVID. And I finally had to say, look, guys, I said, we have to all agree this is the COVID policy. If a child is asymptomatic and tests positive, just because we're testing asymptomatic patients, okay, you got to wait 10 days because of infectivity. But if they have symptoms, how do we treat all of our other kids that come in with URIs for elective surgery? You wait a month. That's what we do. So don't make up different rules as you go along, And so anyway, the more we can all agree on a framework of what's good, what isn't good, and how we're going to schedule things, the less conflict you'll have with your surgical colleagues. So a lot of this is ability, affability, and availability. And, looking at stipends that we're all getting probably versus the value that we're giving for that. And once again, whose efficiency is it? And it may differ if you're in a closed system or an academic health center, or, versus if you're in a private practice where you're trying to really, get that business coming into the hospital from more private practice surgeons. It is a shared responsibility for all of us, and we need to work collegially to make the ORs as efficient and safe as we can. And these current staffing challenges require consensus solutions. We can't do it alone. We need to work together on that. And I think I already visited with you a little bit about the workforce imbalance that we're having right now. So competition for surgeons' cases does cause poor OR utilization decisions, and a hospital may say, okay, I'm good with that. I'm okay. It's worth it to me to be inefficient with these other resources to get that business into my hospital. Well, everybody knows that's inefficient, but they are willing to do that. Okay, that's fine. But realize that we're in short supply. Anything we can do to smooth the data is helpful. And once again, we can improve efficiency and reduce stipends if we can improve it enough. If we get more efficient, then we've got more payments coming in, and we don't have to have as much of a subsidy if we're efficient with resources. So get involved, be a leader. And when you're developing your value proposition or answering an RFP, focus on those problems that matter most to your customer, and that's usually the hospital CEO. Focus on any unresolved problems, making sure that you're handling those at a lower level. Do it well. In other words, visit with them. I know we have a problem. This is what we're working on. Visit with them 3 months later. We fixed it. Now we're going to work on this problem. Go beyond the functional and address the emotional and social. What do I mean about that? It's about developing relationships with people. When things don't go well, and mistakes happens to all of us, we're human, you can rely on that trusted relationship. And sometimes that means showing up at your hospital fundraiser, contributing to their foundation, being a leader in the community, showing that you really care about their success as well. And so some of that is sort of this social, emotional. You need to focus on the things that have the greatest return, the biggest bang for your buck. Differentiate yourself from the competitors. If you're doing an RP and you think some huge group is coming in, well, what can you offer that they probably can't? And outperform outperform the competition on at least one dimension, become really difficult to copy. So, really determine who is your customer, how can you improve your practice's emotional intelligence. We all think we're doing a great job every day, but I can tell you it helps, and other practices have done this, if you get an outside consultant or if you take your blinders off and go and say, hey, can I look at this other great practice across the nation and see how you're doing and benchmark with them. It also helps if you do a 360 every once in a while and you get anonymous surveys from your surgeons and ask, how are we doing? Or from your nursing staff, how are we doing? How are my individual people in my group doing? It helps to get that 360 honest feedback from people so that you can continue to improve. And then always execute on your value proposition when you get it. So you should be difficult to replace, and I think you are. And that's integral to the success of a hospital system, believe me. So just keep offering that high quality of patient service to your colleagues and to your patients, and you'll be able to keep your job. Anyway, thank you so much, and I'm here, I think, for a good amount of time for questions.
Thank you so much, Mary Dell, for that very wonderful overview and sort of the insider education. I'd like to welcome the audience to ask questions. There's a microphone here in the center that may help us with being able to hear. And if anyone has questions, please come forward and we'll be happy to cover those. In the meantime, while the audience is making their way to the mic and finding some courage to ask their questions, I wanted to ask you one idea I hear often, especially from junior colleagues, is the idea that they want to go into leadership. Maybe it would be their group leadership versus thinking even larger than that in C-suite and organizational leadership. I'm curious what recommendations you would have for someone from a professional development standpoint thinking about going into a leadership position. Do they need an MBA or an MMM, or what would you suggest?
Yeah, so that's a great question, Jennifer, and I think depends on what area of leadership you want to go into and what your passion is. For me, I always thought it was important to understand finance, how a group operates. That's why I ended up being treasurer of ASA and all. And it's not that I love accounting that much. I really don't. But I think understanding how the money comes in and where it goes gives you some power, that knowledge of understanding, and it also gives you a bridge in talking with your administrator colleagues on the other side. And so, that's, kind of an MBA does some of that. It helps you with that. I didn't choose MBA route. I had that choice. I actually chose a master's in healthcare administration because I was more interested eventually, I think, in learning hospital leadership was one, and the other was a practical consideration. The MBA programs at the time that would have had healthcare as a bent, it would have required travel to Houston like every other weekend for 2 years, and I had 2 kids and another on the way, and I was working full-time. And so I chose instead the Trinity University program, which was 3 years, so it was longer. But the way it was organized, I thought it gave a broader perspective. It really just dealt with healthcare. And in my class, we had, maybe 2 or 3 physicians, but the rest were all people that were sort of not physicians or not clinical. And it helped, I think, me understand, who I would be working with and communicating with and getting on the same page. And the other thing is about 25% of the hospital CEOs in Texas went to Trinity University. And so, you have this huge network too. So I think kind of depends. Now, some people will get like an MPH because they're interested sort of in another area. Maybe if you want to be a CMO or something like that, you might want to do that. So I think there's various paths, but I do encourage people, regardless of where you want to end up, I think you can go a long way without getting any of these master's levels degrees by, some of the resources that I think our professional organizations are already offering, and put your toe in the water, see if you're interested in, like the Executive Leadership Program or looking at some of these other resources where you can learn. I know I was talking to somebody that did the old CBA program at ASA, where you learn about how anesthesia billing and collection and running a practice and what that all entails. So I think there's various pathways. And for people that don't like any of that all, Joy Hawkins was at our TSA meeting a weekend or so ago, and she says, I didn't like any of that stuff. So I chose a different path. I chose a path of, and she didn't want to do like basic research, but she chose another way of becoming a leader in obstetric anesthesia without that. So, some of it has to be your passion.
Thank you. Jim, you have a question.
Hi, James Griffin. I want to say what a great lecture that was. I thought everything was right on point. One of the points I wanted to bring up is the notion of how hospitals have evolved over the years. With hospitalists coming on board, we lost so much of our medical staff, and more the mid-level providers are making up a lot more of that. And I think that as hospital-based physicians, we're that much more valuable to hospital administration, and we need to be there to help run the hospital. From my own experience, we were all independent and formed a group about 7 years ago. And as soon as we formed the group, the hospital said, okay, we have an RFP now for several other groups, and basically made us compete against nationwide anesthesia groups. So I think a lot of the things we did very well and worked out well, and I just wanted to bring a couple of them up because I think we, what's the phrase? Under promise and over deliver, I think. But one of the things we did was we set up a system whereby we compensated members of our group to serve on peer review. I was chair of credentials committee, people are on MedExec, and I think that really, that presence in the hospital adds value to the anesthesia group. The other thing we did, among other things, you excuse me, you mentioned the first starts of the day, and they may not be the most important, but the optics are very, very important. And we were never as bad as the surgeons, because I think surgeons always were much worse than we were. But when we started data collection, we made a system whereby if you're late once, you get a warning. You're late twice, you get docked $500. And if you're late 3 times in 6 months, you get docked $1,000. And we all agreed to this, and we went from, I don't know, maybe 5% to basically 0 overnight. And that really shone through to administration. And when you showed this data, it was so powerful to add value to our group like that. And then I think the surgeons even try to do it with their own group, but and it helped immensely. So just food for thought.
Thank you so much for that. I would say that some of the things that you have done are really forward thinking, ensuring that you value the time that the individuals in your department are spending on some of the thankless committees of the hospital. I probably served on every committee in a hospital that there ever was, P&T committee, infection control, blah, blah, chief of the medical staff. But I think, when you do that, doors are open, you gain respect of your colleagues, you get to know people in different arenas. They can see you not just as an anesthesiologist, but as a perioperative physician that really knows a lot about a lot of things. And so I commend you on, all that work, and like you said, making sure that you outshine the surgeons on any metric there is, and that the group is all on board and, incentivized or penalized, however you choose to do it. Carrots are usually better than sticks, but, making sure that people see the data and are really putting their best foot forward every day.
Alan.
Alan Isher, Tampa, Florida. A great lecture. My question is about call. We are in a period of great expansion, and so we're actually recruiting like 10 new faculty. So I have a question in both directions. Younger faculty that are in their 30s, we're bringing on they don't want to take call. And we don't even take that much call to begin with. And then on the other end, we have older faculty that are, say, 67 and up. They don't want to take call. So do you have any suggestions or strategies on how you handle that, like where you work? Are they able to opt out of call at one point? And if so, what's the penalty?
Yeah, so this is a big issue, and this is something that a lot of groups are grappling with, I would say. The systems that I've seen in larger groups, and you may have to have a certain critical mass for this to work, but some of the larger groups I'm aware, first of all, to make partner where you're going to enjoy the most benefits in the long run in the group, you have to agree to take an equivalent amount of call. Now, they have a non-partnership track where you can work on these alternative, either non-call or reduced schedule or whatever, and you're going to take a pretty big financial hit for doing that. But some people choose that. So having that option on the table is a good option. But what's interesting is what I've seen some of the larger groups do that's fascinating to me, especially if you're covering, a lot of hospitals, is they'll basically do like what the airline flight attendants do, is they'll put the call schedule on the open market. And they will value call depending on the supply demand of people wanting to take that call. So let's say you're an older physician that, it's like, God, call wipes me out. I can't just do call anymore. So you put your call out on the market, and there's a certain amount of dollars that's assigned to that. And it may be different. So if you're working at the county indigent hospital doing trauma care or OB care, that's a very painful call, that's going to be valued more than, you're just having to basically sleep overnight with maybe a couple of cases at a community hospital. And so, they kind of look at, okay, who are the takers or not, and it all happens before you get your paycheck. So it all kind of goes on the open market. But if nobody takes the call, you still have to take the call. In other words, if you're a partner, you have to take your fair share of call. But if there's enough buyers and sellers, now my son is in a group in Austin where they do this, and of course, I guess in Austin, it costs $1 gajillion to buy a house. And so a lot of the young people, are taking extra call so that they can afford to buy a house. And so you have some that are go-getters, you have others, they've decided from the very beginning, either they have a, two-physician family or their spouse does something where they don't need the extra income, and they're willing to forego that and take the economic hit. So there's some very creative things going on out there, and I've actually encouraged our group as it's grown we're looking at this now, to lower our base compensation and put that into the call pool. And then you would have this buying and selling, on kind of a market system. And so we're looking at trying to implement that, a similar kind of model next year. Because I've got, I think, enough people at this point on both sides that it would probably be fairly equilibrium.
Dr. Peterson, thanks for being here. And thanks for your staunch support of our profession in the last couple of years as well. My question, or I guess I'd be asking for your comments on, over the last, really during the COVID year, the last 2 years, there's been a significant decrease in our private practice model. I think 12 to 15% over the last 2 years, at least the last literature that I read. As an administrator, if you're RFPing, most of those groups that are going to put forth proposals are large corporate entities, private equity groups. Where do the smaller private practice groups go? Myself, I'm a group that just got bought out. So there's a lot of angst, and I think there's a fair number of colleagues likely within this room that have been in the same position. So where as an administrator do you see sort of the future of our profession going? I think the cat's out of the bag. And then on top of that, you mentioned, particularly for young leaders developing, there's residents that graduate, they won't have that experience in knowing how the business of a anesthesia group is run, nor any concept of billing when it's a complete foreign concept to them.
Thank you for that. I think this is a very difficult question to that we're dealing with right now. And we're seeing it not just in anesthesia, we're seeing it across medicine, right? Part of it I do blame on our poor government payer mix, but that's not going to get fixed right away. That's unfortunately a reality that we keep working towards. And so I know ASA has created sort of a new ad hoc committee just for people like yourself who are in smaller or medium-sized private practice groups to really understand what resources and help do we need, in getting there. There's still a lot, over half of people practicing anesthesia in the U.S. are in still small to medium groups. So although it's shrinking, it's still a significant percentage are in there. And it's not like some of the larger private equity ones where they've acquired practices have always been, have gotten these contracts, have always been successful. I have seen a couple of instances where they weren't able to deliver, and it just created all kinds of havoc, and they actually flipped it back, and the hospital systems, canceled it and went back to the older model of a coverage arrangement with a more localized group. So I don't have a great answer for you, except, like the prior speaker, of really trying to have those critical conversations, with the hospital administrators, trying to nip problems in the bud, and provide the best care you can. Part of the, it's not so, when I look at other physician practices, we're also seeing, just even as a children's health system, people coming to me saying, hey, would you buy out my practice? It's like, I've got enough on my plate. I don't really need to be, doing all this. I'd rather have a good relationship with you, and we've got a health plan. So we're able to do contracting and not own practices, but make sure they're financially viable and all through other means. But I think the federal government has gotten what it wanted, and it's unfortunate because I think it's going to lead to more expensive care overall, because what happens is, it's just reality, publicly traded, private equity, they're going to want their margin, right? And it's a big margin, and that's not going to go back into healthcare. That goes into the shareholders instead of actually paying the providers, what it's costing. And so that's going to escalate eventually the cost. When you look at, I was just at a Texas Medical Association meeting, and some of the physicians, because they know I'm a hospital administrator, were complaining to me, and they said, well, it's really hard, in private practice. I said, yeah, I know, my husband's probably in the last cardiology private practice there is. And yet, if his practice got bought out by the hospital, which it probably will at some point, automatically they'll make 30% more on every echo and EKG they do, just by place of service. It's the same echo, it's the same EKG, it's the same person reading it, but the technical fee, it's not in the professional fees, but the technical fee is going to be so much more than what they get. And CMS is aware of this, but they haven't done anything about it. I have my chief financial officer saying, look, we've got some of our clinics, specialty clinics that are hospital-based and some that are non-hospital-based. I want to turn them all into hospital-based because this is how many millions more dollars we can make. What do I say? I'm like, yeah, we already have a shortage. I could use the money in hiring more people. Why do I say no? What are the ramifications if I say yes to this? And so, unfortunately, in my opinion, my humble opinion, we get what the design of the system that's being paid for, and unfortunately, I think in the long run, It's going to be more expensive care and not necessarily any better care, and more disruptive care. We've seen how disruptive it is when you've got non-competes and you have these huge practice turnovers. You've seen it hit the news around the country, and there may be some good reasons why the incumbent group is thrown out, and there may not be good reasons. There's litigation on those kinds of things, so I don't know that. But I wish I had a better answer for you. That's about the best I can do right now, though.
You mentioned just briefly the idea of the workforce shortages here in your previous answer, and I'm just curious. You also mentioned earlier that you're working on some editorial with respect to this. Any insights that you could provide with the audience here today regarding do we have hope? We're feeling the pinch right now. Is there hope for the future?
I'm ever the optimist, and I always think there's hope for the future. And I think the biggest hope. How many of you are in academic training institutions or residents rotate through or whatever? I think you can share with your colleagues the amazing young talent that's coming into our profession, and that gives me hope. Yes, that they have a different perspective on sort of that work-life integration, but I don't think they're any less dedicated to being great physicians. And so we need to harness what is important to them. We're matching at a huge percent. I saw the slides, the DOs and MDs are both, everybody's matching at a huge percent, and we're turning down thousands of young people who I am sure are qualified to be great anesthesiologists. So the opportunity I see, even though Medicare is frozen the funding for GME slots since 1997, which I hope they'll see the light and change that, but there is still opportunity for us to expand our pipelines through partnerships with private practices, community hospitals, and the great educators like are in this room that have the wherewithal of doing it and helping us with the didactics. But we've got the caseloads in these hospitals. And I know HCA has started their own training program. There's some other systems that are starting their own. And I really think that we've got good talent that's out there. Medical students are very interested in our profession. Now, that's not a short-term solution, Jennifer. So, that pipeline is 4 years, minimum, right, of getting more of those. And, of course, it takes longer just to get a residency up and going. But we need to be thinking that way because of the demand for our services. The other thing we need to work on, and I got a lot of email from my colleagues, especially the women colleagues when I was president, about how toxic the work environment is in private practice. And so while we may have made some progress in, the operating room, quote, hostile work environment with the old days where surgeons were throwing things and, behaving badly, we're not where we need to be. And I think showing respect for each other, respect for our colleagues, really, having that human element and really looking at the needs of young people coming into practice and what they're trying to do and juggle and their extra financial pressures that they had that maybe we didn't even have. And so I think we need to make sure we're developing a workplace culture where they feel valued and part of governance and decision making. And Michael Lewis is on one of the task force. He's at Henry Ford Hospital in Detroit, and so he's done a lot of work in this arena with his faculty, and saying, look, this is the care we need to provide. You help me come up with the solutions in how we're going to do this and provide some flexibility for all those other challenges that you have in your life, right? So I think we've got to slow down the attrition and the baby boomers. I had this conversation with the folks in my group, and I know some are past retirement age, actually, and I go and I say, I love what you're doing. I love you being here every day. I walk in the operating room. I said, I need to know for planning purposes, how long do you want to still be full pace, full time, full call, blah, blah. And after those conversations, I had 4 people that came up to me and they said, we would like to go half-time next year. It basically be a half FTE, so you would have, and they get full benefits. We have full benefits even if you're half-time. And I said, well, thank you, because I think I can keep them longer in the workforce if they're happy and they can not be burned out and too exhausted. It does take longer to recover when you're 65 years old and taking call than when you're 45 years old. And so I think, we need to work on those solutions, but that also tells me I need to add 2 more FTEs, and start recruiting for them now. And this is the recruitment time. So I think having those conversations on attrition, and then there's that whole demand side that I kind of talked about a little bit in this, and it's having those critical conversations to slow up the demand, to work with your colleagues, especially on the sedation and NORA procedures, on some of those that, frankly, in my opinion, we don't have to personally deliver that service. We can provide other constructs of great, safe care by training sedation nurses, our colleagues, and other people, making sure there's correct monitoring and guardrails in place, and then we're monitoring the quality as department directors of anesthesia to make sure that quality of care and patient safety is still there. But we don't have to personally provide it to make sure that it's being done in a quality way. So I think teaching our colleagues how to do that is important.
Well, I'd like to ask the audience to join with me in thanking Dr. Peterson for her wonderful presentation and for joining us here.